Hi, this is Angela Enriquez, and I am doing my final PowerPoint presentation on rheumatoid arthritis. I'm doing this for Nursing 606. Today's date is January 18, 2019, and this is for Nursing 606. So this page is a certificate of original authorship. It is signed by me at the bottom, and I will upload the YouTube address as soon as I upload this PowerPoint presentation to YouTube. Rheumatoid arthritis. What is rheumatoid arthritis? Rheumatoid arthritis is an autoimmune disease. It mistakenly attacks the healthy tissue of the joints instead of viruses and bacteria. This causes inflammation inside the joints to thicken. Pain and loss of joint mobility is the result. When the rheumatoid arthritis attacks the joint, it attacks the synovial fluid. This creates inflammation that causes the tissue inside of the synovium to thicken, resulting in swelling and pain around the joints. The synovium makes a fluid that lubricates the joints and helps them move smoothly. So without that synovial fluid, we are unable to have that smooth glide of our joints, thus causing inflammation and hypoxic tissue. What happens if inflammation goes untreated? Cartilage can be damaged. The bones and elastic tissue that covers the ends will deteriorate. The spacing between the bones will be reduced. Joint deformity can occur. Joint damage cannot at this point, and I want to say that, cannot be reversed at this point. So early detection and getting treated is of utmost importance. So who's under attack? Approximately 1.5 million people in America have rheumatoid arthritis. This is 1.5 million people in the U.S. that have rheumatoid arthritis. 3 times as many women have the disease as compared to men, and it usually shows its signs between the ages of 30 and 60, and that's a pretty wide age range. And men usually show signs later in life. There's been some controversy that I found throughout my research as to why men show signs later in life, and I have it's basically been narrowed down to that men either aren't being forthright with their primary care provider when they're in pain, and or they have laborious jobs and they're just attributing that pain to the pain that they're getting from the laborious jobs. So again, there's controversy, and I didn't want to put too much into it since there isn't a specific test or data on that. Genetics. Well, you basically won the genetic lottery because really having a family history will increase the odds of getting rheumatoid arthritis, but the majority of the population of those with rheumatoid arthritis do not have a family history. So if you have a mother and father that are positive for the rheumatoid factor, your chances of getting rheumatoid arthritis is higher, but for the majority of the population not to have any factor, it still remains a mystery amongst the medical community. Genetics continued. Many genes have been studied to find a genetic cause for rheumatoid arthritis. The links have shown that most, if not all, of the genes studied involved in the immune system function are involved in the cause. So anything that can cause your immune system to go down is involved in rheumatoid arthritis. The most prominent gene, though, is the human leukocyte genes. So it's HLA-DRB1 gene. The proteins produced from HLA genes help to distinguish the body's own protein from foreign invaders. And this is where in rheumatoid arthritis it has a breakdown, so it's not detecting foreign invaders, it's actually detecting synovial fluid as being an invader, and it is attacking itself. So when it does that, you have an overall risk of developing the condition of rheumatoid arthritis. Pathophysiology of rheumatoid arthritis. Innate and adaptive immune and inflammatory process involvement. So you have synovitis, swelling, and joint damage. Pathophysiology onward. Environmental and genetic lottery. Result in loss of self-proteins that contain citrulline residual are caused by environmental factors and some genetics. The citrulline proteins are generated by post-translation modification of arginine to citrulline by the enzyme peptide glarginine deaminase. Individuals with shared eptogenes generate citrullinid peptides are no longer recognized as self, but by the immune system. So basically, the citrullineated peptides are no longer recognized as being a normal part of the body. It is actually recognized as being such as a virus or a bacteria. So the ACPA develops against them and starts to form that inflammation. It forms a decrease of the synovial fluid and also swelling of those joints. Pathophysiology, moving on. ACPA precedes inflammation and adhesion molecule formation in the synovium. Synovitis is a consequence of leukocyte infiltration in the synovium. Leukocytes in the synovium results from migration of leukocytes from distant sites of formation. The interior of the inflamed synovium is hypoxic. Decreased vascular growth is replaced by inflammation and narrowing of the joint. So just a quick, I put notes down here. The nature of these interactions is greatly affected by the local cytokine and the chemokine environment of the synovium in which they take place. In established rheumatoid arthritis, the synovial membrane is populated by a variety of inflammatory cell types that work together to cause joint destruction. So it goes beyond just joint inflammation and pain, it goes to actually joint destruction. Evidence-based treatment plan. Goal to treat the underlying inflammatory disease. This goes to say you're out playing a softball game and you pull your shoulder. You then sustain some swelling in that shoulder. We want to treat that inflammatory disease process before it can go any further, because with rheumatoid arthritis, that not treating the underlying inflammatory disease will lead to long-term destruction of that joint. And so our goal is to get early prevention of the joint destruction. Long-term goal, treatment to prevent joint destruction and prevent any comorbidities to the heart, lungs, or bones. And yes, rheumatoid arthritis does affect more than just the joints of the body. Early treatment and diagnosis, accurate diagnosis, this is an important one, is found to reduce progression and have an overall improved outcome. The expectation is to get patients into remission or near remission, because we don't have a treatment or a cure, we don't have a cure, that was misspoken, to get rid of rheumatoid arthritis, but we most certainly can get it into remission or near remission. And I'm going to go on this a little bit later, but serological testing and a point system developed by the Mayo Clinic has made this a lot easier. So here we go. For evidence-based treatment plan, the Mayo Clinic came up with a table that they basically give everything a point system. And based on the point system is where you're going to fall into the treatment plan. So in 2010, the classification criteria for rheumatoid arthritis became to be the target population, who should be tested. So patients who have at least one joint with a definitive clinical synovitis, so swelling. We're looking for just one joint. They should be tested. Unless they have a reason to have a swelling of that joint. So if you've fallen down and your knee is swollen, that is not reason to be tested. But if you wake up one day, your knee is swollen, and there's no reason for that joint to be swollen, you should definitely go to PCP and have it tested. Patients with synovitis not better accounted for by other disease factors. Classification criteria for rheumatoid arthritis score-based algorithm adds score of categories A through D. So a score greater than 6 through 10 is needed for a definitive classification, and that's going to be done through your laboratory testing. So we're looking for joint involvement. One large joint would be a 0. 2 to 10 large joints are going to give you a 1. 1 to 3 small joints are going to give you a 2, and the reason behind that is that the smaller the joint, the more damage that can occur. So if we're looking at your hands, and we all desperately need our hands to do the things that we do throughout life, if we have swollen, tender, or aching knuckles, they're going to get a higher point scale than if we have a swollen, tender, aching knee. Because they don't have as much synovial fluid as our larger joints, and the swelling can be more detrimental. So if we're looking at this like a compartment syndrome, and we have swelling of the synovial fluid, and then also we have inflammation of the tissues, and we have hypoxia occurring because we're having all of the vascular portions of that joint being compressed, then we can lose all mobility of that joint. So that's why we're getting higher points for the smaller joints. So then we're looking at 4 through 10 smaller joints being a 3. Greater than 10 joints, including at least one small joint, is going to be a 5. So you're getting a higher rating there. So you can have 9 joints that are large, greatly affected, but one small joint tossed in there gives you a 5. And again, if you have less than 6, you're going to score a 0. And they still may decide to do serological testing. Anything greater than a 6, and you're going to score, and you're definitely going to want to have that serological testing or that lab testing to confirm the diagnosis. But they came up with this scoring sheet, especially for providers that aren't they're not familiar with rheumatoid arthritis, or they're not rheumatologists, and this makes it very easy for them to score and send them to the rheumatologist. The table continues. So I talked about ACPA, and that is the citrullineated protein antibody. Formerly, they did not use this. This was not the gold standard, but now is recognized by the American College of Rheumatology as being gold standard test. C-reactive protein, ESR, all of those things are going to be looked at when you're looking at rheumatoid arthritis. This slide goes into pretty much the same thing as the last slide with the number of joints affected, but just know that with the number of joints affected, and the serological testing, we can get a definitive diagnosis and you can be treated very early on. So we have an evidence-based treatment plan beyond the table. So beyond the table that we just went over, there was a study that I found rather interesting because it came from Thailand, and we had 37 highly recognized rheumatologists that formulated a set of recommendations that are accepted now by the American College of Rheumatology, and that's a pretty big deal to be accepted by the American College of Rheumatology, especially for coming from Thailand. Early diagnosis, key main factor. We want to get you diagnosed early so that we can get the steps started. So their next step is medication. They use NSAIDs, they use steroids, anti-rheumatic drugs. So the anti-rheumatic drugs, they do come with some complications, so you need to be monitored carefully. They use anti-malarials, methotrexate, and sulfasalazine drugs. Physiotherapy, that's important regardless of what stage, is that we use that physiotherapy to get you back hopefully close to baseline, and our key again is to get as close to remission or into remission as close as possible. Tight control monitoring. You want to be monitored, especially if we are on these anti-rheumatic drugs, very closely because of the ill side effects they cause. Again, as I said, we're using anti-malarials, methotrexate, and I'll go over some of the contraindications and side effects later on. Evidence-based practice, again, the British Society for Rheumatology, along with using previously mentioned medications, they believe that a holistic approach should be implemented. Physical therapy to keep joint mobility at its optimal function for as long as possible, and adjunct exercise programs keeping the patient at an optimal weight and mobility for as long as possible. And doing this, they use exercise, physical therapy, and other holistic measures. So we're going to use evidence-based treatment. We're going to step further outside the box. Many homeopathic practitioners are looking into gluten-free diets to solve the inflammation of rheumatoid arthritis. Many believe that the patient is allergic to gluten and it causes an inflammatory response from the rheumatoid arthritis. Avoiding gluten is believed to reduce flare-ups in the rheumatoid arthritis. They believe that gluten ingested causes inflammation in other parts of the body, so therefore they're associating it with it getting into the synovial spaces and causing inflammation, and therefore exacerbating rheumatoid arthritis. Evidence-based practice for treatment. Take-home message. Early diagnosis. Again, I can't reiterate that enough. Early diagnosis, because our goal is to get you into remission or as close to remission as possible. 5 separate sites all had the same recommendation. Catch it early. Seek expert advice, which means go to a rheumatologist. So once you get to your PCP, you've caught it early, they want you at a rheumatologist. Use adjunct therapy, holistic approach, medications when necessary. Medications that are used, NSAIDs. These are non-steroidal anti-inflammatory drugs. They're used to relieve pain and reduce inflammation. They come in multiple forms to include topical and oral. So if you have a hard time with adjusting to the oral, you can use topical. They also come in other forms as well. They can be both over-the-counter or by prescription. Caution. Cardiovascular system. Blood pressure may rise with the use of NSAIDs. Gastrointestinal system is short-term use for NSAIDs. It can cause stomach upset, dyspepsia. Long-term use of NSAIDs, especially in high doses, can lead to peptic ulcers and bleeding from the stomach. Liver toxicity. Long-term use of NSAIDs, especially in high doses, can rarely harm the liver, but monitoring the liver function with blood tests may be recommended in some cases. Kidney toxicity, use of NSAIDs, even for a short period of time, can harm the kidneys. This is especially true with people with underlying kidney disease. The blood pressure and the kidney function should be monitored at least once per year, but may need to be checked more often depending on the person's medical conditions. We're looking to at our diabetics, those that have renal impairments. We want to make sure that we monitor those more closely. Our steroids, short-term use, meant to be used as a co-therapy, can cause weight gain, thinning of skin, easily bruising, increased risk of infection, and a weaning period is to come. And I noticed that when I went over this, that a lot of people become non-compliant when they see thinning of skin. This was higher in women than it was men, but it was a cause for them to stop and be non-compliant with therapy. Some medications for antirheumatics. We're looking at the anti-malarias, methotrexate. I want to go over methotrexate because it is used to treat cancer along with rheumatoid arthritis, and it comes in many forms. Close monitoring is required. Sulfasalazine must be monitored closely with lab values. Another thing you may want to mention to your patient that yellow, orange tint in tears, sweat, and urine can come when using this medication. Patient education, key. Early diagnosis, again, key. This comes up in every study and every piece of literature that I found. Follow up with a specialist, a rheumatologist. Make sure to live an active lifestyle that is permitted by your provider. Be open to alternative holistic therapy. The key is remission, not cure. Keep an open dialogue with your provider about medications and cost. So if you have a problem with the cost of the medications, because they can be rather expensive, talk to your provider about maybe using some over-the-counter NSAIDs or finding if you need the anti-rheumatics or you're using methotrexate, maybe that there is a plan out there that can help you with your cost of medications. But keeping an open dialogue with both your provider and the pharmacist can help. If you have religious or ethical issues that would prevent you from taking part in a part of therapy, talk to your provider. Be open, be honest, so that they can find other ways to help you. And here are the references that follow.